Good afternoon and warm welcome. It's a fascinating day, isn't it? Patient safety. What is patient safety? It's a lot to discuss about patient safety. Technical, emotional, safety from a broader perspective. Risk analysis as well. We do risk analysis all the time. When we cross the street, we do risk analysis, don't we? Can I walk across the street now, or should I wait? That's a risk analysis. We should do it all the time. We have heard a lot of different lectures about patient safety. Very, very good. And today, you're going to listen to 3 lectures about this one. My name is Johan Järte. I myself is just a moderator, so you don't want to hear me. But I'm a physician as well, and you hear 3 other physicians coming up. First, Dr. Sven Staender. Who of you that had participated the whole day, you heard him this morning. Then comes Elin Karlsson from Södertälje Hospital. Speak a little bit about knowledge and information, and we will have quality in inpatient safety from Ylva, Pernow. But since we're a little bit late due to the technical problems, we start immediately with Sven. Please welcome Sven Staender.
Thank you, Johan. He's chasing me to keep 10 minutes, so let's go. Wonderful. I love it.
This was just a gift to you because we both love Stockholm archipelago, isn't it so? And since he's from Switzerland, we just said that I need to show you this one.
Very much appreciated. Thank you so much.
Thank you.
That's a really wonderful place. Yeah. Okay. No, but we're talking a little bit about safety culture in healthcare. And those of you who were here in the morning, I mentioned that I'm doing mistakes. Do you see the mistake? It says complexity, because I took the format of my slides and didn't change the title of my lecture. So that's human error. So no, I don't want to talk about complexity. I want to talk about safety culture. I'm used to declare that I have no conflicts of interest. And going right into the problem, we know that we have a lot of harm in healthcare. There are ample statistics, and we heard today in the morning even from Dr. Elin about the scope and the size of the problem in healthcare, and the numbers speak for themselves. We have really a lot of harm in healthcare. The question that came up about 20 years ago when the Institute of Medicine first came up with the numbers from the United States in the year 2000 was, what was the reaction from healthcare? How did healthcare respond to these shocking numbers that first have been published, as I said, in in the year 2000, and did not change that much over the last 20 years? Think back on healthcare. We spend a lot of time and money in technology. We spend a lot on standardization and on procedures. In my hospital, for example, we have over 3,000 standard operating procedures only in my hospital. Impossible to follow. In the United Kingdom, we have 150 publishers of guidelines and 17 guidelines on how to write a guideline. Huh? So this is really an overwhelming information that we are having, and we invested in science and knowledge. This is the growth of publications in an American database of medical scientific information, and you can see the numbers are huge. It's impossible to follow this at all. And what about the healthcare worker? Did we invest in healthcare workers, in the well-being, in the working conditions, teamwork, communication? A little bit. And simulation starts to grow, but it's not yet where it should be. So the threats to safety, from my point of view, are still huge. We have a increasing production pressure because resources are scarce. We have rising demands for safety in our society. We have sometimes heroic treatments and expectation for heroic treatments in sicker and sicker patients. We have, as you've seen, an exponential growth in knowledge. We have an increase in specialization. Try to find a general physician. Try to find a general surgeon. It's impossible, more or less, at least in my country. And with an increasing feasibility and success, this again leads to a reduction in risk awareness. This is kind of a self-fulfilling prophecy. So the question is, can we solve the threats on safety simply through technology guidelines and facts? I don't think so, because when you think back on guidelines and on standardizations, they are coming from the world, as Eric Holnagel said, this is the work as imagined. This is theory, this is the blunt end. This is where we think how the world should look like. And on the other side, we have work as done. This is reality, how the people are doing. So if you think this is your emergency department, if you think these are the flows in your emergency department, this is work as imagined, because work as done is like this. This is a communication in an emergency department. And everybody who is working in clinical practice knows that it's really that complex. Or in other words, this is work as imagined, and this is work as done. There's sometimes huge difference in between. And this brings us to the question of culture at work. And in aviation, for example, in Swiss aviation, they say we do things properly or we don't do things at all. This is a precise statement on the safety culture of this airline. And one of the risk managers who is building this aircraft, this Airbus aircraft, René Amalberti, he's working for Airbus. He came up with a very interesting study about risk in society. He was looking for the risk on this axis and looking for various industries. And you can see that we have very unsafe industries, like, for example, professional fishing. We have offshore drilling, oil industry, chemical industry in between. And then we have nuclear industry and civil aviation as the so-called ultra-safe industries. And then he was looking precisely what is the culture behind. And he was looking, for example, for professional fishing. He was looking, what is the culture of these professional fishermen? And he was asking, not these fishermen. He was asking them who are working in these conditions. So completely different. And he found that they have a context of taking risk is the essence. You cannot avoid risk. You must deal with the risk. The culture is fighter spirit, cult of champions and heroes. The safety model behind is power to the experts, and the training is learning through shadowing and acquiring professional experience. Then he looked at other industries, for example, oil industry or firefighting, and this is the HRO, High Reliability Organizations, you probably already heard of. They have a slightly different context because they say risk cannot be avoided, but it is inherent to the situation. The culture is group intelligence, the team comes here. Safety model is power to the group, and training is teamwork for problem solving. And what about ultra safes? The civil aviation, they are so-called the ultra safe. Risk is excluded as far as possible. Culture is applying procedures, and the safety model is power to the regulators, and the training is teamwork to apply these regulations. Okay. And now comes the interesting part, because now he looked at healthcare. And this is healthcare. In healthcare, we have, for example, in my field, anesthesiology in a no-risk patient, A1 and 2, we are coming from the ultra-safe side. We are more or less like the pilots. We like checklists. Yeah? On the other hand, we have obstetrics. They are coming from the fisherman's side. They are experts. And interesting to see, when I talk to our obstetricians, the cultures collide. Because our obstetrician says, oh, don't worry about checking and everything else. I'm capable, I can do it. And I'm coming from the risk avoidance and say, no, we must plan it a little bit. Yeah? And so we have already, at the first sentence, we have a problem. And the perspective with that is, we cannot concentrate simply on one culture. We must try to find a way to deal with all these different cultures that we have in parallel in our hospitals. And every culture speaks a little bit a different language. And it melts together. It melts together in the question, how are you learning? And as you have seen, the fishermen learn a little bit different than the people from aviation, namely the anesthesiologists. Traditionally, when it comes to learning in hospitals, we have this, we have a continuum of outcome, from a very bad outcome to a good outcome, and this is the number of procedures or activities or duties you do every day. So most of the time, the outcome is as expected. Sometimes it's very exceptional, and sometimes we also have a failure. Yeah? And we are concentrating in our learning experience most of the time on failure. We were looking for the bad apple. We say we want to look for the bad apple, and we want to eliminate the bad apple, and then everything will be fine. So in practice, we say in a theoretical chance of 1 in 10,000 cases, we want to look for this one case, this one, and we ignore the 9,999 other cases that are really going good. And Eric Holnagel once said, it's easier to learn from which is frequent and regular, this one, than from what is infrequent and irregular. So learning from failure and looking for the bad apple is in all of these cultures, regardless whether you are from obstetrics or from anesthesiology, is not telling the whole truth. Because learning from failure is like this, looking and asking, why did this happen? But we also can ask ourselves, learning from success, why does it go well in most of the times? And what can I do to support things that are going well in healthcare? So instead of looking only at the bad apples, this is a so-called concept of safety one, looking at bad apples, but also on success. And this is safety two thinking. So not looking at the failures, but looking at what goes right. I changed this in my department. Traditionally in my department, in the afternoon we were asking what went wrong today. And now we changed, and I remember very well when I did the first meeting, I said, what went right today? Everybody looked at me and said, oh, what did he drink today? Nobody was expecting me that I was asking for success stories. And now we are coming up with the success stories in my department. And the success stories are first much more fun. They are positive because they value the human part and the human being. And there's a lot of learning potential from the success stories. So in summary, there's not just one safety culture in hospitals, but many. We cannot only invest in technology, but also have to invest in the healthcare workers. And we have not only to learn from failure, safety one, but also from success, because we teach our children how to walk and not how to avoid falling. Thank you very much.
Thank you very much, Sven. Short question or a comment. Boris Becker, you remember him, the tennis player? He was failing and failing and failing and failing. And suddenly he started to win. He started to win from failure. And he, on a question, what has happened? Someone told him, well, he said, I started to look on my good shots instead of looking the bad shots.
Yeah. Perfect example. Yeah.
Thank you very much.
You're welcome.
The next is our colleague from Södertälje, a surgeon who will talk about, we'll see.
Yeah.
Here we are. It disappears. I don't know.
Oh, did it disappear?
No.
Yeah, that's this one. Yeah.
There it is. Sorry. There you have.
Thank you so much. Thank you so much for having me here. And thanks for a great lecture, Sven. My name is Elin Karlsson, and I'm a surgeon, but I'm also the chair or the president of the board of the Swedish Association of Hospital Physicians, or sjukhusläkarna, as we say in Sweden. This is a part of the Swedish Medical Association, and we have about 20,000 members, all specialists in hospital care specialties within the hospitals or in the smaller units in outpatient wards and so on. My work at Södertälje, in the Stockholm perspective, it's a very small hospital with limited resources. So I'm very much into what you're saying, Sven, because we always need to plan for elective surgery. What resources do we have? What obstacles can there be? How can we do this as safe as possible? And should we do it here? So that is in our daily work, and it's very important. But I'm mostly going to talk to you as the president of sjukhusläkarna. So patient safety, it is engraved in the very essence of being a physician. We have this old Hippocratic oath that we don't really follow by detail anymore because it's kind of unmodern in many ways, but this one is very important. First, do no harm. But what does it really mean in our everyday life as a doctors? Can we really uphold and guarantee patient safety? Well, we wouldn't be here if we could all the time. As physicians, we must dot every I and cross every T. But that isn't always enough, even though we try to do it as good as we can and plan as good as we can. We need to work in a field that promotes patient safety in every part of the day. And patient safety is important, but it isn't always the top of the mind concern of the regions, from my case of view. I'll present a couple of examples on general threats to patient safety and how these threats can be remedied. For us working in hospitals, one of the biggest threats to patient safety is the lack of hospital beds. We don't have enough hospital beds, and that gives us many problems, and our patients many problems. We have seen in a recent survey from the Swedish Medical Association that 1 out of 7 doctors are forced to send home patients that should have been admitted to the hospital every week. 1 out of 5 are forced to discharge patients earlier than they should. And 2 out of 5 are forced to allocate patients to other wards than they medically belong to. And every week, 2 out of 5 doctors are forced to admit patients without being able to provide a proper hospital bed. And to discharge or admit a patient is always the doctor's responsibility. But a lot of times, when we do have insufficient hospital beds, we have to choose. Is the risk highest for the patient who is in this hospital bed? Is the risk higher if this person goes home for that individual? Or is the risk higher for the patient in the ER waiting to get this hospital bed? So we have to choose all the time. We cannot go by our professional standards all the time. And that causes an ethical stress, and of course it's a risk to patient safety. The Health and Social Care Inspectorate, EVO, has done several inspections of the Swedish hospitals just to see if we are doing what we need to do regarding patient safety. And they see a lot of problems with insufficient number of hospital beds. And we can either talk about insufficient number of hospital beds or lack of personnel, employees working to make those hospital beds properly. But there is a lack of hospital beds where we need them the most. They have been very clear in their criticism and they have demanded actions for several hospitals, and also imposed some penalty payments. And the Director General, Sofia Wallström, has concluded that EVO has a strong legal mandate to protect patient safety, and that they are prepared to shut down hospitals that don't comply to the complaints. We are following their work closely, and we are glad and happy that they're taking their assignment in that they're taking it very seriously. But we also wonder what will happen if they start to close hospitals, and how bad can it be before they start to shut down. I'm going to say some words about the leading, where we from sjukhusläkarna would prefer a different solution than the one we see today. Today, the chief medical officers, the CMOs, and all the directors and so on are hired from the region, so they are in the decision-making line. And that could cause some problems. Sometimes when doctors say that there is a risk, there is a patient safety risk here, we get the answer from the CMOs that your evidence is just from stories, it's anecdotal, the patient safety is not threatened. And we say, yes it is, please listen. But we are on different levels, sometimes, not all of the time. So we would prefer if we could see another way, that the CMOs who are a guarantee for the patient safety, that they actually could have another employer in some way. We also would prefer to have CMOs in the care of the elderly, out in the community care. Today, we have a lot of information about our patients. We have the patient's records, but most of the time it's very hard to find the correct information at the right time. And we have a problem because we don't have a good system with medically responsible doctors. There are in some ways, just as it has to be in primary care, a medically responsible doctor, the patient's doctor, it should be in the hospital care as well. And when you don't see the same patients twice, the patients meet different doctors every time, it's a risk of making mistakes. It's a risk that we don't find the right information in the journal at the right time. It's too blurry. So that is something we think should improve patient safety. And in Sweden, we don't have any, as a patient, you don't have any guarantee that the doctor you meet has updated information. We don't have any requirements for continuing medical education and training. We have recommendation from the Swedish Medical Association. I happen to work in a workspace where my boss thinks it's very important, so I get to go on educations, but many of my colleagues in other clinics, they don't get to. And the education, it's not for me, even though it's nice, of course, to learn something new and meet colleagues and so on, but it is for my patients. It is the patient's right. So I think we should have a regulated continuing medical education and training for all people working with healthcare. So our conclusion from sjukhusläkarna, or from the Swedish Association of Hospital Physicians, is that there is a lot to do to make it better. And we would like it to be the top of the mind concern of the regions. We would like to be able to do our work in our very best way. We would like to have enough number of hospital beds. And when we say that, they say, oh, but it's not enough nurses. But in Sweden, we have more nurses than any other countries. They just don't want to work in healthcare because the working conditions is too bad. So we need to have a workspace where we can stay, where we can last a lifetime of a working career, and where we don't have to quit to spare ourselves because the burden is too heavy. We should have the medically responsible doctors in every case where the patient might need it. And we need the training, of course. So that's pretty much what I wanted to say. Thank you.
Thank you very much, and big applause. Just a short comment. I must say that if we had journalists here, you had a long list for the politicians to take care of.
Yes, I do.
Very good.
Thank
Hospitals,
you so much.
beds, etc., etc. Really good. It's a lot of things that we need to do. And next on board to talk about patient safety is Dr. Ylva Pernow, who is from Karolinska University Hospital. She's Quality and Patient Safety Director. Quality in Patient Safety.
Yes. Thank you very much for inviting me, and it's a pleasure to be here. And this afternoon I will share with you a little bit how we at Karolinska have worked with patient safety dialogues. But first, a few words about Karolinska to get the scope. We're quite a large university hospital, and we are at 2 sites, the north and the south side, with about 20 kilometers in between. Around 1,100 beds and 15,000 employees. The healthcare is organized in interprofessional and interdisciplinary teams, and these teams are organized in theme areas and functions. And I think you recognize the names of the themes, which are quite common: emergency medicine and reparative medicine, children, cancer, and so on. And then we have 2 functions, the medical diagnostics and the perioperative medicine intensive care, supporting all these themes. The themes and functions have medical units and nursing units, and they have a managing director who is responsible for the quality of care and the patient safety. For those of you who were at another session saw this picture, and this is where we want to be, in the green bubble, where you celebrate the success stories and you are aware of all your risks. In Karolinska, I would say that we have all these bubbles. We want to be in the green one. Some of them are, but there are still some who mainly do damage limitation, react when something is wrong, and try to improve. And then we have occasional denials who say that, well, I'm a good doctor, I take care of my own patients. But we want to be in the green bubble. So how do you engage 15,000 people to walk in the same direction and care for patient safety? This is an action plan that the National Board of Healthcare and Welfare presented in 2020, and some of you who might have been at the previous session where this was discussed. This is actually a very, very good healthcare plan, an action plan. And they have a website where there is e-learning, there is workshop materials, so you can really use this out at the ward and the polyclinics to discuss patient safety with your personnel. So we are using this a lot, and we use it as a template when we have these patient safety dialogues, because it's all connected, and you can get all the information from this action plan. So we started with patient safety dialogues for quite some years ago, but then we reorganized and moved to a new hospital, and it sort of faded away for a couple of years. But then we took it up again in 2019 at the request of the CEO. But then came the pandemic, so we had to focus on the units that had COVID care and see that there was good patient safety there. But then last year, we again tried to do it on the theme and function level, which is 8 dialogues. And this year, we have continued to also to do it on the medical units level, which is about 60 patient dialogues. The aim is to have a dialogue with the manager about the patient safety, about the processes, and the participant is the management team of the theme and function and the hospital director, the CEO, CMO, Chief Medical Officer, and Chief Nurse Officer. about an hour, and it should be well prepared in advance. And a physical meeting, preferably. We stick to this action plan for the headlines. So we work with a committed management and clear governance that they should describe their processes. How do they work? How do they ensure that they have a good process? We have an employee survey where we have questions about sustainability and engagement. And they get these results every year, and they should comment on that and see what actions plan do they have to improve. We discuss competence and staffing, competence in patient safety, and we could use this e-learning from the website, but also staffing, of course, and the problem if you lack competence. And they should describe how can they use the patient as a co-creator, and what do they mean by that? And then what are their next risk? What is this next event that they want to prevent? So some examples from the Children's Hospital. We could see that they had a very robust patient safety organization. They had patient safety groups at all levels, and they had reserved time for patient safety work, which is important. And they performed patient safety rounds. They had simulation trainings. They had an onboarding program for new employees in education in patient safety. And at the medical unit level, they had patient safety rounds, including the parents, and they had risk analysis working in the medication room. And for the children's department, medication problems are common in patient safety issues. So, and then we had the risks that they wanted to focus on. And they could see that there was a problem with transportation between our two sites. There were problems with the monitoring capacity in Huddinge and the competence in the children's anesthesiology, complications due to delayed care in the elective care surgery queue, lack of experienced nurses and shortage of beds. And these are questions that not the theme alone can solve. So it's important for the top leading management to get this information. Oh, strange picture. But the success factor in the summary is that the engagement of the top hospital leading team is essential. That the hospital director is there, asking the question, saying that this is important. The yearly follow-up that we have is also a way to stimulate and contribute to the systematic patient safety work. And it was highly appreciated by the medical and nursing units because it visualized that patient safety is important. So you have to talk about it, walk the talk all over the organization. And we get the information about what are the needs of the organization, what do we need to do on a higher level, how can we speak to the region about more hospital beds and so on. So patient safety is created what we all do every day. Thank you very much.
Thank you, Ylva. Yes, it was quite fascinating.
2 seconds.
Yes, 2 seconds. One short question. Well, I'm asking you to come up, both of you. I have a question to you, Ylva, because you're looking as well at the patient, the hospital beds. And so did Elin. Mm. But for me, this is a political decision, isn't it? It's not the CEO of the hospital that can decide this.
No, but I think that, I mean, if you look at the Karolinska, it's often that we lack beds during the day and during the evening, but in the morning, mysteriously, everyone has got a bed, almost. So it is the way we work.
So you think it's an organizational problem as well?
Partly, definitely.
Okay.
Yes. You cannot always blame the politicians. You have to do something yourself.
Oh, yeah. That's very good. I like it. Fantastic performance and fantastic lectures. I never even thought it would be this good as it is. It was really, really good and impressive. I do have one other question to you, because a little bit technical is the solutions You look at the patient beds, you look at the safety, you look at your part of the calls, or what do you call them, the meetings, etc. But today, at the same time, we have an example that I think is a failure in even the Swedish society, but maybe around the world, that we have a lot of suicides. How about the suicides isn't that a failure as well in patient safety? Because all of them has been in the hospitals, come home again, or even in the hospitals, as you told me earlier. Could just hear one or two words from we do not have so much time.
No.
But yes, we have.
Okay.
Yeah.
That's quite a tricky one. I think that dealing with mental diseases and suicidal persons, I mean, it takes a lot of courage from the care personnel to dare to raise the subject and to see that when the patient leaves the hospital, there is an organization who takes care of whom you report over to form a sort of a network or a safety network for this patient. So I think that's a failure, yes. It's a society failure also.
Elin?
Yes, both. It is a society failure, and I've seen numbers, or I've seen reports that we have one suicide each month in elderly people that are getting kicked out of their homes. So of course it's a big problem in society. If we don't have housing, if we don't have the standards we need, some kind of lower standard, it's an unacceptable way, that kind of increases the unhealth and increases suicides. But we also have a problem if we don't have the possibility to take care of the patients in our need, the patients that are seeking help. If they don't meet the same doctor, the same nurse that they can kind of trust, that they can build on, I think that could be a problem. And it can also be a problem that you don't have the beds, I'm coming back to that, or the resources when a patient needs to be in the hospital to get help. So both.
And Sven?
Yes, I could underwrite everything that you have been saying. I think suicide is a failure in society, is a failure in communication, is a failure in the personal network. But precisely when we look, for example, at hospitals, as you've mentioned, we may not forget that we have healthcare people that experience a bad outcome of a patient, perhaps due to a mistake or a complication or whatever, and not very seldom these healthcare people commit suicide. We know that this is really a bad outcome of the so-called second victim. Yeah, but it is a fact, and I think this is a completely breakdown of the structures that we have in hospitals. In Switzerland, for example, we have a campaign how to deal with these second victims as a director of your department or as a colleague. And for example, as a colleague, I'm obliged to ask and to talk to these colleagues and try to support them, try to be supportive, even in the clinical business, and try to help them to get over this bad experience. But I think this is really a breakdown.
Oh, 1,000 of questions, but you may have some questions. Do you have some questions over here? No one? Yes?
They're so tired about the fight they have to go through. Well, now I'm on the kidney ward, and the kidney ward says, no, that's it. Your intestines, and they won't take it because I think it's the heart. And they say, no, it's endochronical, and so on and so on. And if you've been going through the hospital for very many years, having this problem, you get, and I don't know this word in English, but you get livsled. And that has nothing to do with depression.
No.
So it's not a depressive suicide. But I, as a therapist and a social worker at a hospital, meet those patients, and they have no one to talk to. And they have to fight for the place in a bed at the emergency. And who is going to be my PAL? That is quite, patient responsible doctor, but spells out PAL, but sometimes it's not a PAL. This is patient safety at a high level that we have to address.
So your question is,
how do you address the multi-sick patients?
Yeah, thank you.
I think this is a perfect description of what we have due to the specialization that we have in healthcare. Because as we have this growth in knowledge, no single person, even when you concentrate, for example, on general surgery, no one can overlook all the details and all the things that you have to learn in this field. So there is a need for a specialization, but the downside is exactly what you are describing. And I think we are in a trap. It's really a trap, because we cannot reduce the amount of knowledge we have, because we have these wonderful experts. If I have a problem with my shoulder, I would be happy to go to an orthopedic surgeon for shoulder surgery. But in Switzerland, we have a clinic where we have head of departments for upper limbs, and we have head of departments of lower limbs. Orthopedic surgeons specialized that much. And I don't think that we can draw the wheel back, and I think this is already a fact. Unfortunately, but you're completely right.
Yeah, last word.
Yes, I think it is important to have someone responsible anyhow, because I want to know who is my patient's rheumatologist. When we're going to plan this surgery, who should I talk to? I can, of course, ask my patient, and they're going to tell me, but they're going to tell me, oh, I met 10 different doctors the latest years. So who knows? Who knows what is the best? So I think we need to be able to take the medical responsibility and know how to communicate. But we need to see the patient as a whole and work together. And we need to get rid of those like pipelines and boundaries and just work together. And I do think we have some good examples from the pandemic time where we more truly work together as a team around the patients, and I think we need to extract those and use those in the future. So it's very important.
Last 10 seconds, Sven.
Perhaps it would be a good idea to, in the future, invest into patient advocates that have a broad background, and they could guide, for example, a patient with complex disease through the hospital or through the whole journey of his or her disease. That just came into my mind as a possible solution.
Thank you very much. A real pal, isn't it? Real pal. Thank you, and short break now before the next session.